Breasts are the most prominent superficial structure in the anterior thoracic wall, consisting of glandular tissue, supporting fibers, and fatty matrix. Each breast has two regions, the axillary tail and the circular body. The areola has many glands that enlarge during pregnancy, producing an oily lubricant for the nipple. Nipples located at the center of the areola lack fat, hair, and sweat glands. Circular muscle fibers in the nipples compress lactiferous ducts, aiding in milk expression during lactation. The breast stroma is a mix of fatty and fibrous tissues. In a non-lactating state, fat fills most of the breast, and fibrous tissue forms the suspensory ligaments of Cooper, connecting mammary glands to the skin. These ligaments provide support to the lobes. Mammary glands in breast are responsible for lactation, comprising 15 to 20 lobes, each with smaller lobules. These structures contain great black clusters of alveoli, housing milk-producing cells. Ducts, known as lactiferous ducts, connect alveoli, lobules, and lobes. The terminal duct lobular unit, known as TDLU, comprises lobules, an extralobular terminal duct, and an intralobular terminal duct. Apocrine metaplasia is a condition where breast ductal cells transform into cells resembling apocrine glands, often due to inflammation from factors like Staphylococcus aureus infection or hormonal changes, mainly involving estrogen levels. When there is a fluctuation in estrogen levels, estrogen may react with the estrogen receptors on inflammatory cells in the breast. This interaction triggers the secretion of cytokines, signaling other estrogen and inflammatory cells to migrate to the breast. This metaplasia results in structural changes, including duct narrowing, characterized by altered cellular structures, with apocrine cells possess abundant cytoplasm than normal ductal cells. In cases of bacterial infections, white blood cell clusters form, releasing cytokines that cause the vasoconstriction of the ducts. Normal process of apoptosis causing release of epithelial debris into the ducts. The combined effects of ductal narrowing, vasoconstriction, white blood cell clusters or cannonballs, and epithelial debris lead to obstruction of the ducts. This obstruction causes a build-up of fluid from apocrine and mammary gland secretions, forming a complex mixture of lipids, proteins, and milk. As fluids accumulate, the ducts become dilated and surround the apocrine cells and encapsulate the fluid, forming a protective cyst membrane. This encapsulation aims to contain the fluid, preventing uncontrolled spread into surrounding tissues and ensuring safety. Type 1 cysts, known as apocrine cysts, are lined by apocrine cells and have an electrolyte composition similar to intracellular fluid with low sodium and chloride ions and high potassium ions. On the other hand, type 2 cysts or flattened cysts are lined by flattened epithelium and have an electrolyte composition similar to plasma or serum with high sodium and chloride ions and low potassium ions. Focusing on type 1 or apocrine cysts, breast cysts are also classified based on size, which are microcysts that are very small, less than 2.5 cm, and detected incidentally during imaging tests, while macrocysts are larger, 2.5 to 5 cm, and easily felt during a physical examination. Moving on to the mechanism of breast cyst enlargement, from microcyst to macrocyst, there is a thin connecting bridge between microcysts. Factors such as fluid pressure and peptidases cause this bridge to rupture, combining two or more microcysts and leading to the formation of macrocysts. Rupture of the connecting bridge can occur through fluid pressure alone, as fluid accumulation increases pressure inside the microcyst, forcing a rupture. Alternatively, the combination of fluid pressure and peptidases weakens the connecting bridge protein structure, leading to rupture and emerging of microcyst contents, resulting in cyst enlargement. The potential for apocrine cysts to develop into carcinoma is not definitively known. Studies have identified markers like 50-PGDH and HMG-CoA reductase in both apocrine cysts and carcinoma, suggesting they could serve as early predators. However, the certainty of this remains unclear. In some studies, the transition from ductal to apocrine cells lead to changes. Apocrine cells are androgen receptor positive, but estrogen receptor and progesterone receptor negative, indicating a low risk of carcinoma development. Despite uncertainty, individuals with apocrine cysts often have a favorable prognosis, with the condition often subsiding after menopause. Those with a family history of breast cancer face a double risk, regardless of fibrocystic breast features. For those with no or mild symptoms, treatment is usually unnecessary. However, severe pain or life cysts may require intervention like close follow-up, pain relief, warm compresses, fluid drainage through fine needle aspiration cytology, and lifestyle adjustments such as wearing a well-fitting bra and reducing caffeine intake. In conclusion, fibrocystic breasts, despite the potential risks associated with hyperplasia, generally have a favorable prognosis and are not inherently linked to breast cancer.